Morning, everyone, or I think it's almost afternoon on the East Coast, but morning for sure for everyone elsewhere. Can you see my screen? Can you hear me? Anybody? Okay, great.
Yes.
Good. So I'm very pleased to be able to speak with you today. Ms. Walker, Ms. Beckett asked me if I would talk to this austere group, the Regional Association for Admission Officers and Registrars, and speak specifically about the implication of the COVID-19 vaccine for colleges and universities. My name is Roy Weiss, and I wear many hats here at the University of Miami. My favorite one is the fact that I'm the chief medical officer for the university for COVID-19. This is distinct from any roles that we play, even though we have a very high-powered academic health center associated with the university. The Board of Trustees and the president felt that during the pandemic especially, it was really important to have someone identified as the chief medical officer that would help make decisions and involve everyone with regard to the COVID-19 pandemic. I also, in my spare time, happen to be chairman of the Department of Medicine, which is about 400 full-time faculty here at the University of Miami with 14 different divisions and another 400 or 500 voluntary faculty, and I'm a professor of medicine as well. So with that as a brief introduction, I'm going to begin by discussing the vaccines and making sure that we're all on the same point of understanding of what the vaccines are, so that we can then move on to a discussion about the implications for colleges and universities. Well, this is the cover of Science Magazine. Science Magazine is probably, if not the most, one of the most respected journals of science, of medicine in the world. And on the last issue of December of 2020, it said that the scientific breakthrough of the year was indeed the vaccine. Truly, the establishment of a vaccine has altered our understanding and our ability to cope with the pandemic in ways that we only could have hoped for a year ago. And in fact, on December 15th, 2020, at the University of Miami and many other places throughout the United States, we had made history. It was indeed a historic day. That was when we got our first shipment of vaccines, and we began vaccinating our first line healthcare providers, whether they were directors of nursing and taking care of our patients at the bedside, whether they were individuals that were involved in food services and delivering food to our COVID positive patients, or individuals in environmental services that were responsible for cleaning the room. It was important, and still is important during this pandemic, to be sure that the people who care for us when we're ill are the ones that we protect, at least on the front line. So this is just a pictorial review of what happened that day. But let's get to the meat of the matter. Why do we even need vaccines? Why are they necessary? Why can't we just invent drugs that will cure the virus? And we're doing that as well. But vaccines are really important because the SARS-CoV-2 virus is highly transmissible by the respiratory route. And if you get it, as you know, it can be very serious. Furthermore, people that don't even know they have the virus can transfer it to other people. It's either they're asymptomatic or it's before they even become symptomatic. And so therefore the virus can spread wildly in a population. And if left to its own devices, the infection will become endemic. That is, it'll reach a steady state, because herd immunity, which we'll talk about in just a few minutes, is very unlikely in the absence of a vaccine. And of course, we need to curtail the major economic and human impact that COVID-19 has had. So these are the reasons why vaccines are necessary. Vaccines have been around for a long time. As back as 1796, cowpox was the first vaccine that was developed. But it was discovered that they called them handmaidens at the time, a term we wouldn't use necessarily today, that milked the cows, noticed that on the udders of the cows there were vesicles that were then transmitted to the people who were milking the cows, and they were transmitted to other people. And they discovered there was some substance in the pus of these vesicles, turns out it was a virus, that if they were to give it in small doses to people, it could prevent the it could cause what's called vaccination. And in 1853 in the UK, there actually was mandatory vaccination required because smallpox was so rampant. And then in 1885, rabies, and then measles vaccines and mumps vaccines. And probably what's very relevant for us on college campuses and universities is the discovery of the pneumococcal and meningococcal vaccine, that we know in residence halls, if meningococcus gets out, it can devastate and kill very quickly individuals that are not properly vaccinated or are susceptible. So vaccines have been part of our medical armamentarium for centuries, and it's very important that we aren't afraid of the vaccines that we have. But a vaccine will only work if you take it. And so we have all heard about the lack of confidence, what we call vaccine confidence, especially in the COVID-19 vaccine. And this is data that was released a week ago last Friday to another prestigious journal, Nature, where they were able to determine, based on a global survey comparing November 2020 to January 2021, how many individuals would take a COVID vaccine if it were offered to me this week. And the other question was, I'm worried about the side effect of COVID vaccines. So the good news is that although the number of individuals that strongly agreed they would take the vaccine went from 30 to over 40% between November and January, and the number of individuals that were worried about side effects of the virus also decreased, we still aren't at the appropriate number that we need to be at for people who are willing to take what is now this voluntary vaccine. And we'll talk about that in just a minute. So what are the reasons why people give for not wanting to take the vaccine? It's mainly because they're concerned about the long-term effects of the virus or of the vaccine is unknown. You might experience serious side effects from the vaccine. The vaccines are not as safe as they say they're to be. The vaccines are not as effective as they say they're to be. And they might get COVID-19 from the vaccine, all of which is incorrect and wrong. In looking at this in a different way, if you look at the profiles of individuals who have that perception of the vaccines, if 34% of people in this Kaiser Foundation evaluation thought that they would get it as quickly as they can, and the larger group, 39%, said they'd wait and see how it's working. And then smaller percents get it only if it's required for work or school, and then others that would just definitely not get it. And when you looked at the demographics of the people in each of these bubbles as to who would definitely get it, who would wait a little bit, you can see their political, age, race, and education play a big part in determining who decides whether or not they would take this vaccine. And in terms of race, we are making some headway. If you look here in the middle part, these are the number of individuals compared in September compared to December in the Black and Hispanic and white communities, that the individuals that definitely would get it went from 50% to 62% in the Black community, and from 60% to 71% in the Hispanic community. And I point those communities out because they started off with the lowest individuals that would definitely get it, to probably get it, and also those that would probably not and definitely not get it. So we are making some headway in that regard. But the most common excuse is that I don't know what's in that vaccine. I don't want it. I'm not going to take it. So I love this cartoon, which really drives home the point. Let me get this straight. You've eaten hot dogs your entire life, but won't take a COVID vaccine because you're not sure what's in it. Do you know what's in hot dogs? I don't need to tell you. So let me just tell you a little bit to demystify this concept of what these vaccines are, especially the RNA vaccine, which is in fact new. And when you think about the diamond age of medicine, that in 1 year we were able to go from the identification of a pandemic to the presence of a vaccine, it's mind-boggling. But let me explain to you how it works, just for a brief moment. And if this is too elementary and basic for you, forgive me for wasting 2 minutes of your time, and then we'll move on. But this represents here, this little ball that you see at the top of this cartoon is really a little ball we call it a nanoparticle because it's so small, and it's surrounded by little lipid droplets, little fat droplets. And in fact, if you want to know what the rate limiting step is for manufacturers to make these nanoparticles, it's finding a source for these little lipid molecules here. So these little lipid molecules form a little ball, if you will. And located inside the ball is a tiny strand of something called RNA. RNA is the blueprint for all proteins that are present in the world, in the biosphere, in anything you can imagine. It codes for proteins. So a tiny little piece of RNA gets encased in this little ball of lipids. And then they're put together into a syringe, and then they're injected into your arm muscle, your deltoid muscle. And there, the little lipid droplets coalesce and form on the surface of your muscle cells and release the RNA into the cytoplasm. It doesn't become part of your DNA. It doesn't become part of your genetic workup, but that RNA is sitting there, and that RNA then uses the machinery of the cell to make a protein. That protein is specific for the SARS-CoV-2 virus, and no other virus has that protein. So it gets the protein revved up. The immune cells of the body sense that this is not a normal protein. This is a protein coming from a virus. And so it gets antibodies ready, sort of like a boxer in a boxing ring, getting ready to fight as soon as the opponent comes. So the immune system gets revved up and ready to go. So as soon as a virus comes by, that is the SARS-CoV-2 virus, it's ready to it immunizes you against it because you've been vaccinated with this nanoparticle. And that's the way RNA vaccines work. Now, in fact, there are two types of RNA vaccines, one made by Moderna and one made by Pfizer. And they're both very, very similar. The sequence of the RNA may be off a little bit, and that's one of the reasons why if you got Moderna first, you have to get Moderna second, or Pfizer first, you get Pfizer second, the booster, because you can't mix and match them. They're not identical, but they're formed in the same way. And they're about 94% and 95% efficacious in terms of getting disease, and I'll show you some data later. Now, these were already approved by what we call an emergency use authorization. And an emergency use authorization means that the FDA has enough information that it's okay to release it with the understanding that people know that it isn't fully FDA approved, but there's tens of thousands, in each case about 40,000 people that were tested with the vaccine to know that it's safe and that it works. Now, coming down the pike very shortly are two other type classes of vaccines. One is an adenovirus vector, and the other is a recombinant protein. The difference between this and the RNA virus is that the adenovirus vectors have a small inactivated DNA as opposed to RNA, very much like the measles vaccine that people get. And that's the so-called Janssen or Johnson & Johnson vaccine. And then there's another one made by AstraZeneca and those vaccines are likely to become available. The advantage, they're maybe not as highly efficacious as the Moderna and the Pfizer, but they're much easier to administer because they are only one dose, as opposed to the RNA viruses, which must be given a dose and then a booster 3 to 4 weeks later. And they don't need to be stored at minus 80 degrees centigrade in order to keep them potent. So, uh-oh, I think I froze. Am I frozen? I'm going to have to sign off.
Yes, a little.
I'm going to sign off and sign back on again. Please bear with me. It will be 2 minutes.
Hi, everybody. This is Karen. I'm moderating this for Dr. Weiss. As you can see, there's always fun with Zoom. So he will be back on momentarily, and we will finish the presentation. So thanks for your patience. If you wanted to ask a question at the end, just put your name in the chat, and I'll go through the folks when we get to the end of his presentation. We did leave time for questions. Thanks.
I'm terribly sorry. I'm back. Just give me a second to load the slides again.
No worries. We know it happens.
Oh my gosh, it's so embarrassing. This is
Don't worry. We're fine.
okay. So we're up to this. I'm not going to. Can you see my screen? Can you see my
Yes.
screen? Okay, good.
Yes.
So, okay, so we talked about the 3 different types of vaccines. The only one that's available now is the RNA vaccine. Then there's the DNA coming down the pike, and then there's the Novavax and Sanofi vaccines, which are not injecting any DNA. It's just injecting the protein itself. And these are going to have to require very frequent injections and boosters, and we'll learn more about that. So what do we know about the safety of these vaccines? Well, in general, these vaccines are very safe. There have been no deaths directly attributed to the vaccine. A couple of people that received the vaccine might have died, but it wasn't directly due to the vaccine itself. Almost everybody gets some pain at the injection site. It's almost impossible to get a needle in your arm and not have pain. 60% have fatigue, 50% had some headache, myalgia, chills, arthralgia, fever. It's not much different than a flu shot, and it's usually more on the second dose, the booster, than it is in the first. And the important thing is that these are very mild to moderate in severity and resolve in a few days. So when does the vaccine start working and how long does it last? So here's an example of both on the left, the Pfizer vaccine, and on the right, the Moderna vaccine. And these are on the x-axis is the days after the first dose and days from randomization in the case of Moderna. And the red line that you see here is the placebo, that is, they received salt water, half the 40,000 people, and then the blue line is those that received the vaccine. And in both instances, you can see clearly the effectiveness of the vaccine that compared to placebo in terms of the cumulative incidence of individuals that develop the disease. And if you see the number of individuals that developed very severe disease in the Pfizer, they all received, except for one, the salt water, and only one that received the vaccine had a severe disease. So it does prevent infection, and it certainly prevents severe infection. Now, what's this business about herd immunity? So herd immunity is the indirect protection from an infectious disease that occurs when a population is immune through vaccination or previous infection. Herd immunity threshold for SARS-CoV-2 it needs to be determined, but in general, we believe between 70 to 85% of the population or of the bubble of the population that you live in is vaccinated or has been infected, that there's no longer a danger in getting severe disease. However, there are challenges to achieving this herd immunity. There's the vaccine hesitancy, which I talked about at the beginning, the unknown role of vaccines in preventing transmission. You might have heard of some new variants that may or may not be susceptible to the vaccine, and the fact that although we showed graphs that the vaccine lasts for many, many months, up to 6 and 12 months, but over a period of time, it may wane. Now, when you think about herd immunity, I love this Larson cartoon because it says here, it's a known fact that sheep that give us steel wool have no natural enemies. So it's true, if you can repel the virus and keep the virus away, these sheep will live forever. Let me just illustrate this in a little bit bigger picture here. And these little figures, and if they're in blue, they mean that somebody is not immunized but still healthy. If they're little golden figures, they're immunized and healthy. And if they're red, they're not immunized, they're sick, and they're contagious. So take where we were in March, if you will, or February of last year, and you see all these blue people that are not immunized but still healthy, and then 1 or 2 non-immunized sick people. And when no one is immunized, the disease spreads rapidly in the population, and that's what happened. When some of the population is immunized, the disease spreads through some of the population, and the ones that are immunized won't get it, but still the majority of the people are susceptible and will turn red, will get sick and become contagious and give it to others, till ultimately all the blue people will get it as well. Now, when most of the population is immunized, when most of them are golden, which is that 75 to 80% number, even if there's two people that didn't get the disease, and there may be one that still hasn't got, rather two people that got the disease and one that still hasn't gotten it, they're not going to be able to really interact very closely with these other three. So you can slow the spread down. And that's what it means by herd immunity. So once the vaccines were manufactured, the federal government determined how we would allocate the vaccines based on phases, based on importance and the need to have these individuals vaccinated. And there was phase 1A, B, C, and 2. And the idea was the first group would be healthcare professionals, then frontline essential workers, people over the age of 75 who were really most vulnerable to getting severe infections, and then various other groups. And you can see the total number of millions of people in each of these groups, hundreds of millions, with only a few million vaccines. So quickly, one had to develop mechanisms by which to triage these vaccines to the people that needed it the most. Now, I remind everyone, whatever state you're in, it's the same story. A state of confusion, right? Though whatever state people are in, the point is that Pfizer and Moderna manufacture the vaccines. But after that, the government, the federal government bought them and they own them. And then the federal government distributes the vaccines through distributors or directly through FedEx and UPS to the states. And it's the states, the Department of Health for the various states, that determine how in the state the vaccines get relegated. And when they get to students and faculty on campuses is way down the line. So the National Academy of Medicine and the CDC and the Advisory Committee on Immunization Practices developed three major ethical principles that we followed in order to administer the vaccine: to maximize benefits, minimize harm, promote justice, and mitigate health inequities, and promote transparency as the meta principle. So whatever process you had, we had to be sure that we were transparent in how we did that. So we set up a committee to determine how our vaccines would be allocated. And we had internists and a pediatrician, an infectious disease expert, a biomedical ethicist, our chief operating officer, chief medical informatics officer, medical legal experts, and administrators, all to help us design the rollout. And this was the phases. Now remember, there were three types of characterization of the phases. The federal government had their theory. The state government has their own. Here in Florida, we had our own. And then the university developed its own phases, but they had to be in sync, at least somewhat, with the federal and state governments. So it's not important, the details. I don't expect you to read them in this slide, but the idea is that in phase 5 and 6 is when we would start, provided we got enough vaccines to give to the students and the faculty, and that we would prioritize those that were most vulnerable based on medical conditions and age, and then those that were in the classroom and had face-to-face classroom experience. This is a listing of the CDC defined high-risk conditions, and nowhere in this list do you see occupation of a teacher or something, and nowhere in the list do you see donor or wealthy as being a high-risk condition. So you have to be very careful to make sure that we don't distribute the vaccines in an inappropriate manner. So where does this leave us in the last several minutes as university campuses, and what are the implications for a vaccine? Well, first, on the one hand, we need to obtain herd immunity. In order to obtain herd immunity, we got to vaccinate 75 to 80% of the individuals or have them infected, and they come in and out of a community. So it really is going to be a while until we have true herd immunity. But once we have vaccines that are readily available, as they are becoming this week, 20% more vaccines will be released by the Pfizer and the Moderna forms, and then we'll have the J&J and the Sanofi in the future. Will they be voluntary or required? Are we going to make students have to get these vaccines and the faculty like we do the flu shots, or will it be voluntary? Right now, it has to be voluntary because it's under what I said in EUA, an emergency use authorization. We have very weak grounds to make this a requirement at this point. Then you have to decide for your university what are the best phases to roll these out in. What would have the first priority? What would have the second priority? Individuals, for example, that take care of our students in isolation or quarantine, they were already inoculated. As soon as we got our first batch, we consider them frontline health workers and gave them vaccines. Then how do you distribute these vaccines? When will you distribute? Where will you distribute it? The vaccines are provided free of cost. That is not a problem. However, injecting the vaccine, having the informatics infrastructure to do all of that costs approximately $1 million a month just to give the vaccines. So it's not trivial, although the cost of the vaccine is free. And then how would you decide if it was optional? How could you determine who could opt in and opt out? What mechanisms do we have for that? Well, we use Workday and the student medical record to allow students to opt in or opt out. And then would you give them vaccination passports so that if people had the vaccines, would they be treated differently in terms of their freedom to move around campus and go to classes versus those that didn't have vaccines? And would we continue to do testing, tracking, and tracing as all of us do? Those are all great questions, which I'm sure you said, well, Weiss, why didn't you just give us those answers? That's what we came to hear you say. But I would tell you, I don't have the answers now. Nobody has the answers. Maybe in a couple of months or even maybe a month from now, we'll have more clarity in that. So in the meantime, while the vaccine is likely to start working now, and some of us have gotten the vaccines, we don't know when these antibodies are going to be fully protective. We don't know how long it's going to last. So it's still prudent to expect people on campus to wear masks, maintain social distancing, and practice good hygiene. The point is, there is light at the end of the tunnel. We're still in the tunnel. We still have a way to go, but we can see the light at the end. And so with that, I'll stop and be happy to answer any questions that people have.
Great. Thank you so much, Dr. Weiss. I have 2 questions already in the chat. One has to do with if they have an infection right now, I guess unrelated to the vaccine, and they're scheduled to get their vaccine, do they need to wait until the infection clears up? Should they postpone the vaccine?
Exactly. So if you are getting, I presume they're sick with COVID, but even if they're sick with the flu or something else, do not get the vaccine when you're ill. That's generally always the rule of thumb. If it's COVID, you really need to be out of isolation before you should go in public to get the vaccine, because you don't want to expose anybody, whether you're following the 10 or 14-day CDC guidelines. So you do need to wait until you're out of quarantine and out of isolation, and you shouldn't be ill with it. Now, if you're sick with COVID, we know that people are protected for approximately 90 days. And so therefore, there's no urgency to get the vaccine during those 90 days. And you might want to allow someone else to get the vaccine before you, because you could wait a little bit. You're going to likely be somewhat immune. However, the bigger conundrum is when you got the first vaccine and then you get sick and then you miss your second vaccine dose. What do? Well, don't worry, you can still get the second vaccine dose even after a month after you should have been scheduled to get it, if you've been sick with COVID. I hope that answers.
Okay, the next question asks, if a person gets the Moderna vaccine the first time and gets the Pfizer the second, does this mean that the vaccine is not as powerful? Can you explain further why this is not recommended?
Yeah, it's absolutely not recommended, mainly because the Pfizer vaccine, as I explained, has a little thread of RNA. And the Moderna vaccine has also a thread of RNA, but they're two different proteins, two different parts of the spike protein of the virus. So if you get the let's say the Pfizer first, and then the booster is to boost your immunity because it's more of the same, by taking the Pfizer, by taking Moderna instead of Pfizer as the second dose, you sort of lose the oomph that you would get, so to speak, if you were to take both of the same. Now, so it's definitely not recommended. And I know, at least in the state of Florida, we refuse to give anybody to mix the vaccines of the different manufacturers, because it's definitely not recommended. You won't get sick, God forbid, nothing will happen to you, but it decreases the effectiveness of the virus, of the vaccine.
Okay. The next question says, what is the long-term effect from the vaccine?
Look, these studies were done for both the Moderna and the Pfizer vaccine in 40,000 people. The data is still being analyzed. There's no reason to believe, based on our understanding of vaccines, that there will be any long-term effects of these vaccines. Now, at some point, one would say, well, why don't I'll wait a couple of years to see if these people that got the vaccine are still healthy. The problem with that approach is that if you end up getting COVID-19, you won't necessarily be around to know the answer to that question. So I wouldn't wait to figure that one out. I hate to be so blunt, but.
All right, we don't mind. Okay, the next question says, my understanding is that the CDC revised their data and now has determined that over 95% of folks actually recover from COVID. So why do we need to continue to push the vaccine?
Well, I'm not so sure that 95% recover without any sequela. You may know that COVID, the SARS-CoV-2 virus, although people may not die, there are long-term sequelae of viral infections that people live with many months after their initial infection. It can affect the kidneys, the nervous system, the heart, as well as the lungs, the hormone, the endocrine system. So there's a variety of other organ systems that are known to be effective. And at some point, there are people that will die from it, even if it's, and I don't believe it's that low, but 5%, especially, depends what age group you're looking at. And so that would be the reason.
So I had a question, and I know it's come up in several of our email listservs. It has to do with the ability to go back to somewhat normal classroom capacities this fall. Do you have any opinion on that, or I don't want to say predictions, but
that was a great, I'm trying to read, I can't read all the chats at this time, but so that's a great question. And I wish I had a crystal ball to know for certainty, but I think based on the rate of immunizations that we anticipate, based on the infections that we're having, based on current practices, I think by fall, there should really be, people should be making plans to resume a somewhat normal, or what would be a new normal, in-person classroom experience. I don't think we'll need plexiglass partitions. I do think there'll be some degree of testing going on campus just to monitor things, because as variants develop, we don't know, and that may change this whole prediction based on what we see over the next 2 to 3 months. I think mid-March through April will be a very important period of time. And I know that we don't really have the luxury of waiting until April and May to determine what are we going to do in the fall, because you need to make plans now. So I think it's reasonable to make plans for a more normalized in-person experience, but I think one needs to be cautious and totally mindful of what's happening, especially if we have another spike as predicted at the beginning of April with variant viruses.
Okay, great. I know that was on a lot of folks' minds. Okay, we have another question here. After you get your vaccine and you are around others who've also had the vaccine, do you still need to wear masks and social distance?
For now, that's the dogma that we want people, in other words, you didn't get the vaccine, but all the people around you did, right? Is that what you're saying? Is that the
No,
question?
they're saying they've gotten their vaccine and the folks around them have also gotten it.
So it makes it very unlikely that anybody in that small group will get sick if it's a small group. But I think it's that's probably true. But would I still wear masks in public? The answer would probably be yes, until we get more information about the infectivity and what's going on with variants in the community. But the idea is that you probably could be relaxed a little bit if you knew for a fact that everyone not just got their vaccine, but their booster, and was a week after that and were healthy. They may still have the virus in their nasal passage, but they won't be able to infect you seriously or anyone else in that small group.
Okay, I think you answered this, but it sounds like someone might have missed it. What is the latest data on how long the natural immunity lasts if you've had COVID-19? Is it still 90 days?
The thinking right now is that it's 90 days. Yes.
And then another question was, when do they expect to start doing testing for younger children under 16? So for employees who have younger kids, is there any light on that horizon?
Yes, as a matter of fact, all the pharmaceutical companies are currently now testing kids between 12. The first group will be 12 to 16, and then they'll go back and younger than 12. So they are already doing such trials now throughout the United States. And in fact, there were some children that were immunized, or younger people that were immunized in some of the trials, but the numbers weren't too robust to make any conclusions. But now they're specifically answering that question.
Okay, great. All right, those were all the questions that were in the box. Real fast before we let Dr. Weiss go back to his day job. Anyone else have a question?
Well, thank you very much, Karen, for giving me the opportunity to speak to you. If anything, I hope I enlightened somebody somewhat about what the vaccines are and how they work. And I do not have all the answers as to how your campuses will run come the fall, but at least you have at least an informed understanding of what the vaccines can potentially offer. So thanks so much, and good luck to all of you for the major work that you do, because keeping our universities open really is what protects our society more than vaccines. So thank you.
Thank you so much, Dr. Weiss. All right, thank you all so much. Enjoy the rest of the conference. If you have any other questions, feel free to shoot us an email and we'll see what we can find out for you. Have a good afternoon. Bye-bye.